Right, good afternoon, everyone. So welcome to this Association of Physicians webinar on renal medicine. And today we're going to talk about acute kidney injury, which is a topic of great interest to me. So I'm Paddy Mark, I'm Professor of Nephrology at the University of Glasgow. This webinar is being recorded for the Association of Physicians YouTube channel, so feel free to catch up there. But a bit of housekeeping before I introduce our two eminent speakers. So first of all, this will be recorded for the YouTube channel. So if you have to duck out, you will be able to catch up on it there. I will obviously encourage questions of our speakers. Please use the Q&A function to ask questions rather than the chat. We really encourage it through the Q&A. It's easier to work from there, and delighted to field the questions. Unfortunately, we can't go live for questions, so they will have to come in through the Q&A. Don't worry about typos. I will tidy those up. If you get any comments through, please put them through there. And now I would be extremely grateful. I will introduce our speakers in the order that they speak. So first up, with an introduction to what topic, we'll say acute kidney injury, but with long-term consequences, I'm going to introduce my colleague, Professor Nick Selby, who's Professor of Nephrology at the University of Nottingham, who works as a consultant nephrologist in Derby. And Nick's been a leader in acute kidney injury research for a long time in the United Kingdom, and holds grants from NIHR for renal imaging, but I think most impressively has done trials of cluster randomized control trials of step wedge interventions to improve outcomes in acute kidney injury, or test out improve outcomes acute kidney injury. And he's published extensively in the field, previously led the UK Renal Association acute kidney injury clinical study group. And I could list many, many more achievements, but I'll hand over to Nick to introduce the topic.
Thanks, Paddy. So I'll just share my screen. Coming through okay?
Yep, that looks good.
Great, perfect. Well, afternoon, everybody. It's a great pleasure to be taking part in this webinar on acute kidney injury. And in this first talk of the session, I will try and cover some aspects of the epidemiology of AKI, but also discuss some specific areas of AKI, maybe from a slightly more clinical perspective. So as we all know, AKI is a syndrome characterized by a sudden reduction in kidney function. It's defined according to internationally accepted criteria, as shown here on this slide. And the KDIGO criteria that we now all ascribe to describe 3 different stages of AKI in increasing severity, based on the magnitude of change in an individual's serum creatinine from their baseline or their usual serum creatinine value, or maybe less commonly in clinical practice, the degree of oliguria that they're experiencing. Patients with complete kidney failure sometimes need temporary kidney replacement therapy or dialysis, and these patients are within AKI stage 3. But this group, although small in number, has specific care requirements and unfortunately often have the worst prognosis. I think very importantly to say at the outset, AKI is not a specialist topic. The vast majority of cases are seen and managed across all medical and surgical specialties. And the headline messages surrounding AKI really sort of underlie, sort of highlight its clinical need in the fact that it's very common in patients who are hospitalised. And it's associated with extremely poor outcomes, and particularly high mortality rates. AKI often presents alongside other acute illnesses or following complex surgery, but its lack of clinical signs or symptoms in part explain why we often see variation in the quality of AKI care. And these variations in the quality of care sometimes contribute to the poor patient outcomes. But how common is common? Well, even conservative estimates put the global burden of AKI at greater than 3 million patients affected by AKI every year across the globe. The map shown here shows the percentage of hospitalized patients affected by AKI across different regions of the world. And clearly in some areas, if we sort of look at the north and west of Africa, these low numbers likely reflect issues around testing and access to healthcare, so that there may be some reliability questions around some of the figures. But that apart, across both low, middle and high income countries, you can see the rates of AKI in hospitalized patients are consistently very high, at least 10 to 20% of hospital admissions. And one fairly remarkable thing about the AKI diagnostic criteria is how they retain their associations with poor outcomes, in particular with mortality across a very wide range of healthcare settings. Beyond that, however, as you'd probably expect, there are very different characteristics when you look at acute kidney injury in high versus lower income countries, as summarized on this slide. So as we are probably more familiar with, AKI in high income countries often occurs in the setting of acute illness or following surgery, often in older patients, often many of whom have long-term conditions that increase their risk of AKI. Conversely, in lower income countries, AKI is often seen in younger age groups and is often related to communicable diseases. So infectious causes, poisoning and obstetric complications are a much greater cause of AKI in that setting. And what's happened to the epidemiology of AKI over time? And I think there are sort of two themes. I think the first is that increased incidence of AKI, and that's complicated to look at because changes in diagnostic criteria that have expanded the number of patients who we now classify as having AKI, plus increased awareness and testing has an effect on that. But this slide shows what's happened to the incidence of dialysis requiring AKI over the last 30 or 40 years. And possibly this is a metric that's less affected by changes in the AKI definition, although clearly not immune from changes in practice around sort of initiation of dialysis. However, maybe a slightly more robust number. And you can see as you run down that right-hand column, there's been a sustained and significant and very consistently reported increase in AKI over the last few decades. At the same time, there's been a trend towards an actual improvement in mortality. And again, this might be affected by a change in the denominator as we widen the scope in terms of the patients that we define as having AKI. But over time, and again, fairly consistent report, a fall in mortality. But I think maybe the most important thing to note from this graph that even with that fall, mortality rates still remain exceptionally high. So above 20% in hospitalized patients with AKI, as compared to the 2 or 3% that you'd see across non-elective admissions. It's also widely accepted that AKI is associated with hugely increased healthcare costs, and these have been calculated in a variety of different ways and demonstrated across a number of different healthcare systems. And here are just some examples from the UK, Canada, and the US that sort of estimate these hugely increased healthcare costs associated with AKI. And some of that comes from longer, more complicated acute admissions, but quite a lot of it comes from the long-term consequences of AKI and the impact that AKI has on longer-term health. So within the spectrum of AKI, it's also possible to delineate differences between the various clinical settings in which AKI occurs. And this heterogeneity of the syndrome, I think, is something that we'll keep returning to throughout this webinar. So on this slide, there's some common scenarios here where AKI is seen, so cardiac surgery, following chemotherapy, sepsis in the ICU, and probably the biggest case load in terms of patient numbers, acute medical admissions or medical patients in the emergency room. And the table at the bottom just illustrates both the range of incidence, a requirement for kidney replacement therapy, but also the different outcomes. And it's not that surprising, but very, very striking that AKI associated with sepsis has particularly bad outcomes. So traditionally, we've been taught to sort of approach this heterogeneity of AKI by determining the cause from a clinical basis. And as summarized on this slide, we've been taught how to think about pre and post-renal factors versus those intrinsic renal diseases. As again, as is fairly common knowledge, the vast majority of AKI cases fall in that left-hand column, and around about 80% of AKI are due to one or more of these pre-renal factors. But I think it's really important to critique this approach and recognize that there are some fairly big caveats with this approach. Most importantly, that these pre-renal causes that tend to be sort of lumped together are clearly not the same, and multiple insults can coexist. And so it's not always a clear-cut decision as to the cause of AKI. And just to illustrate that, there are some specific circumstances in which AKI does behave really quite differently, and these are important to highlight. And the first of that is AKI in heart failure. Again, at a population level, a combination of AKI and decompensated heart failure often is still associated with worse outcomes, but that's actually not the most important aspect. The characteristics of AKI and heart failure are very different. So you very rarely see acute tubular necrosis. Biomarkers of kidney damage don't associate in the normal ways. And the most important driver of outcome is actually response to diuretic. So AKI that occurs in the setting of treating decompensated heart failure no longer holds the same associations with poor outcomes if the patient is responding to diuretic. So treating the heart failure and decongesting the patient is actually the key driver of outcome in this situation. And that's important to recognize to make sure that the AKI isn't misinterpreted in that scenario. I think contrast-associated AKI is also an area that still causes a lot of clinical concern and questions. But again, I think the thinking has shifted significantly. There are just two examples of randomized trials on this slide of interventions to try and reduce the incidence of contrast-associated AKI. On the left with coronary angiography, and on the right predominantly with IV contrast for CT scanning. And I think importantly, the thing to note is the low rates of acute kidney injury, even in higher risk groups. And that change of appreciation, I think, is important clinically, because there's also risk of not performing a diagnostic test or a vascular intervention, and trying to make sure that balance of risk to actually much more in our favor, giving the contrast if it's clinically indicated, is important. The patient perspective of AKI is also interesting because this has a number of effects on that might influence subsequent care, choices around medications and adherence to that, and also decisions around follow-up and prioritization of that. And this is a slide from a few years ago now from the Think Kidneys program, but it was asking questions of the general public to test their knowledge of kidney function and risk factors for kidney disease. And really, quite surprisingly, only about half of people who were polled knew that the kidneys actually made urine. And the understanding of risk factors for kidney disease on the bar chart on the right was actually pretty poor indeed. So there's an educational aspect around acute kidney injury and when looking after these patients that may have a big influence on their patient care. As we have a bit of a slant in this webinar today to focus on the long-term outcomes of AKI, I think discussing the epidemiology of that will hopefully lead into Bean's talk next. But the 80% of people who survive an episode of AKI are exposed to a variety of adverse long-term consequences, and they include the progression or the development of chronic kidney disease, cardiovascular risk, in particular heart failure, hospital readmission, which sometimes happens very quickly after discharge, and a variety of other risks have been reported. And these probably combine and affect aspects such as frailty and quality of life for patients. One question that's often been asked is how strong is the causal relationship, in particular between AKI and CKD? And I think to summarize a large body of evidence now, I think that is pretty strong. And in addition to that, there's some nice examples of studies such as this one, in which AKI episodes during follow-up of large cohort studies allow a very clear demonstration of the effect of AKI on proteinuria as another marker of kidney damage, and very convincingly show that episodes of AKI increase proteinuria. I think there's also a number of reasons of why the AKI to CKD transition is in particular has in particular importance to focus on. And the first of that is it's pretty well described in terms of the complex pathophysiological mechanisms that drive that change, at least in the animal models of AKI. And that's in contrast to the association of AKI with some of the other more systemic outcomes in which the biological pathways may be less clear. Further, the degree to which the kidney function recovers after an episode of AKI may be a really important driver of other outcomes. So on this slide, I'm going to show you data from the ARID study, which is a prospective matched parallel group observational study in which we followed patients with AKI and a group who did not have AKI out to 5 years. And as you'd expect, shown in the Kaplan-Meier curve at the top of the slide, the AKI group had worse survivals and higher mortality rates. But importantly, that association between AKI and mortality, and also between AKI and heart failure events, disappeared when adjusted for eGFR and albuminuria at 3 months. So the degree of recovery after an episode is what drives that association, not the AKI episode per se. So just to summarize this opening talk then, we've described some features of the AKI syndrome, both in terms of the epidemiology, but also some important clinical scenarios that might behave slightly differently. And just then finishing with the variety of long-term adverse outcomes that occur after an episode of AKI, but then particularly focusing down into the importance of the AKI to CKD transition. Thank you.
Thanks, Nick. So I think we should have a little bit of discussion about this. And I think, first of all, thank you for such a brilliant overview of both the clinical problem, but also some other insights into, first of all, the complications, and also some of the introducing into Beans for some of the translational mechanisms. So thank you for such a great overview of the topic. I guess I was struck again. It's rare on one level, super common on another level. Do you think the problem that AKI sits in so many specialties has been a hindrance to research? Or, I mean, it's a self-fulfilling question, but it seems surprising to see it across oncology, cardiology, general medicine, sepsis, and yet it seems to me that only nephrologists and to some extent critical care doctors are interested in this topic, and which I find pretty odd. What are your thoughts on interactions with other specialties, funders, labs, etc.?
No, I think you're absolutely right, Paddy, and I think as sort of nephrologists and critical care sort of specialists, one of our sort of roles is that sort of leadership, both sort of on the clinical side, but also in sort of driving research. It is harder, clearly, to sort of plan research when the cases are distributed, but it's not impossible, and certainly with some organization linking to sort of electronic screening reports, remote recruitment, that type of thing. They're the types of approaches that allow you to sort of get around that. And I think by doing that and getting out into these other areas, that's the sort of the start of trying to engage the other specialties and sort of garner that interest. And I think the other thing that sort of often hinders the sort of interest in it is the lack of interventions at the moment. There's this so what question, really. And I think it's our duty to try and sort of show what can be done by sort of doing the basic things well, but also fly the flag a little bit in terms of the opportunities that are coming down the pipeline from research, new therapeutics, and options from repurposing drugs, maybe. So there's lots there, and it's trying to sort of increase the awareness of that.
Yeah, I mean, obviously we could come back to this, but I was wondering, we talk about interventions. First of all, I guess it's difficult to deliver interventions, and presumably there are a variety of interventions that have not worked. I mean, classically, or may have worked and then probably haven't worked. Things like N-acetylcysteine for contrast nephropathy, or alkalization for contrast nephropathy. And I guess what's the current state of interventions to prevent AKI?
Yes, I mean, I think we'll sort of get on to that maybe a little bit later in the webinar, but I think we probably don't have a lot of time to sort of discuss lots of different individual trials. So I think there are some new therapeutics that have sort of come through to phase 2 and phase 3. So recombinant alkaline phosphatase is one that's just their phase 3 trial, unfortunately, stopped early due to fertility on the mortality signal, but there was a secondary endpoint that suggested possible kidney benefit. Mm-hmm. There are a number of pharma companies who now have pipelines with new therapeutics for AKI. And then the question is also arises from some of the new CKD treatments that we've seen, in particular the SGLT2 inhibitors, which I'm sure we'll mention again as the new sort of wonder drugs for CKD, but evidence to suggest there might be value in thinking about repurposing those for secondary prevention in AKI.
Certainly, the most recent meta-analysis said less AKI in people taking those drugs, which is kind of counterintuitive to the early safety signals. So so there's probably a lot to talk about. But I'm aware that Bean is probably champing at the bit to get started. I was very keen, are both expert speakers, but Bean has published some really nice work recently on translational work on sort of preventing complications of AKI in translational studies. But to introduce, Bean is, or Dr. Bean Dawn is a clinical senior lecturer at the University of Edinburgh, and he must be good because I'm from Glasgow and inviting somebody from Edinburgh. He's also, I think, the Scottish senior clinician scientist at the minute, and previously has been a British Heart Foundation intermediate fellow. And he's forever publishing in the high-end cardiovascular and nephrology journals, both in insights into AKI and also, other interests would include vasculitis, cardiovascular complications of CKD, and I'd like to say you sit very much in the translational stuff, but also do some epidemiology and trials as well. So I'm really excited to hear what you've got to say today, Bean.
Thank you, Paddy. Right, I'll just share my screen. Is that good?
That is good. And I'm delighted to see there is a Q&A coming in, but we will save that. So I'm sorry to whoever submitted that. I will have a chance to read it now. I was so excited. But on you go, and then we'll deal with Q&A at the end of Bean's talk.
Brilliant. Right. Give me 1 second. Great. Thank you, Paddy. Good afternoon, everyone. As Paddy said, my name's Bean. I work in Edinburgh, and really appreciate Paddy asking me to speak to you today. And I'm delighted to be talking about translational approaches to improving outcomes in patients with AKI. And Nick very kindly set the scene well for this talk. So as Nick said, acute kidney injury is associated with development of chronic kidney disease. And perhaps slightly different to Nick's data, I mean, my reading of it is that acute kidney injury, whether it recovers or not, is associated with an increased risk of CKD. And not only is AKI associated with the risk of progression to chronic kidney disease, but you're also at increased risk of cardiovascular disease. And certainly data from America would suggest that this is true regardless of whether you recover kidney function or not. And not only are the episodes such as heart failure, myocardial infarction, stroke more common after AKI, but the outcomes following these cardiovascular events are also poorer for patients who previously had AKI. And as Nick said, and as we were discussing, there are no treatments at the moment which prevent this progression from AKI to both chronic kidney and cardiovascular disease. And not only do we not have any treatments at the moment, but we're not actually able to stratify those patients with AKI who are going to go on to develop CKD or cardiovascular disease. I mean, it's fine if at 3 months you've got impaired creatinine still and you can say you've got CKD, but this risk is still there 2, 3, 4, 5 years down the line. At the moment, we don't routinely see these patients for follow-up, certainly in the UK. So what we need are not only treatments, but better ways of stratifying these patients at the start of their AKI into who may or may not progress. So as Paddy very kindly said, we've been doing some work recently, which we published a few months ago, about looking at one particular pathway that might be involved in AKI and its complications, and that is the endothelin pathway. So this endothelin it's a 21 amino acid peptide. It's produced by the endothelium, as the name might suggest, and it's released from the endothelium towards the underlying smooth muscle cell, where it acts on the endothelin A receptors to cause vasoconstriction. And many of the pathological effects of this peptide are mediated by the A receptor. There's also a B receptor, the endothelin B receptor, which is present on endothelial cells, where when ET1 acts on these receptors, you get the release of nitric oxide, which mediates vasodilatation. So this pathway has shown to be important in the progression of CKD to kidney failure. And there have been clinical trials showing that if you intervene with endothelin antagonists in patients with diabetic nephropathy in particular, you can reduce the risk of kidney failure as well as cardiovascular disease. But actually the role of this system in acute kidney injury and its complications has not really been examined previously. So we recruited some patients with AKI, and as Nick said before, AKI is very heterogeneous. These patients had medical AKI, so these were not patients in the intensive care unit, they were not patients in cardiothoracic wards, they were patients who came into the general medical wards. So we recruited 30 patients presenting to the medical wards with AKI and matched them with 30 age and sex matched healthy subjects. And we measured the endothelin system in these subjects. And what you can see on the left is plasma endothelin 1. And hopefully you can see the orange circles which represent the patients with AKI. There was elevated plasma ET in these patients compared to healthy volunteers. In the middle, you see urinary endothelin, which is considered to be a measure of kidney production of endothelin. And that was also elevated in these subjects. In a few of the subjects, we also did kidney biopsies when we weren't sure why they had AKI or there was some doubt based on the history. And in those few subjects who had a kidney biopsy, we looked at a message for the ET system and compared it to healthy kidney. And what we found was that all components of the endothelin system were upregulated, but particularly the endothelin A receptor, which, as I said earlier, mediates many of the pathological effects. We then invited these patients back to see us again about 90 days later. And this is the point at which, if you've still got impaired kidney function after an episode of AKI, you'd be considered to have chronic kidney disease. And of the 30 subjects we saw initially, about 25 came back. And we reassessed the markers we'd done when they first came into hospital. And what I've shown you here are two specific markers of AKI, which are urinary measures, neutrophil gelatinase associated lipocalin on the left, and kidney injury molecule 1 on the right. And both of these markers fell considerably back to kind of healthy levels, suggesting that AKI had resolved. However, of the 25 subjects who came back, 18 had definitely recovered kidney function and had no evidence of cardiovascular disease. 8 of the 25 subjects who came back had either got impaired kidney function and so had CKD, or had hypertension, which we used as a surrogate of cardiovascular disease. And in those 8 subjects, we found that plasma ET had either not changed or gone up. And similarly, we saw the same thing with urinary ET. So based on those clinical data suggesting a rapid change and a sustained change in the endothelin system, we generated a kind of a reasonably novel model of AKI, which then progresses to both chronic kidney disease and cardiovascular disease. And we did that in mice, where what we did was we clamped the renal artery to one of the kidneys for 50 minutes, and we then let the clamp off and let the kidney reperfuse. And over the period of 4 weeks, this ischemic kidney shriveled up, became fibrosic, whereas contralateral kidney remained intact. And what you see here is at the bottom in the immunohistochemistry is just histological representation of the fibrosis we saw in the kidney, and at the top you see the weights in the kidney with the IRI mice in red compared to the non-interventional control mice in black. And what you see is the IRI kidney has a reduced weight, whereas a contralateral kidney in the IRI mouse tends to have a slightly enlarged kidney as a compensatory mechanism. And we found that in this model, all components of the endothelin system are also upregulated by the 4-week time point. And what you see here is the IRI mice in red, the control mice in black. The hashed bars represent kidney medulla, and the open bars kidney cortex. And hopefully, while I've been saying all that, you can see that the endothelin system is upregulated both in cortex and medulla. So, having defined that model, we hypothesized that if the endothelin system was important in AKI and its complications, that if you blocked it pharmacologically, that you should be able to prevent the transition to not only chronic kidney disease, but cardiovascular disease. So we used 2 blockers of the endothelin system. We used a specific blocker of the ETA antagonist, and then a dual blocker of both the A and B receptor. We started the treatments 24 hours after the ischemia and continued them for the whole 4-week period. So this would be a kind of therapeutic approach as opposed to a preventative approach. And the drugs were continued for the whole 4-week period. So essentially, this slide summarizes about 4 years worth of work. And what you see on the left panel is the IRI kidney in the kind of control, in the mice receiving the kind of vehicle, the IRI kidney looking small, shriveled, fibrosic with the kind of nice looking contralateral kidney. The effect of the blocker that only blocked the A receptor, hopefully you can see both kidneys look quite nice. And actually what we found was it completely blocked all the kidney complications of ischemia, whereas the dual blocker of both the A and B receptor had very little effect. We then looked at a number of factors which underpin this. So here, what I've shown you is fibrosis in the kidney, and I've shown you the kind of red staining, which is picrocereus red in the cortex at the top, and quantification of this in the cortex and the medulla at the bottom. And what you can hopefully see is the red circles at the bottom represent the mice that just underwent IRI with just vehicle treatment. The orange circles are the endothelin A antagonist, and the blue circles are the dual AB antagonist. And this is quantification of the histochemistry shown at the top. And what you see is that the A blocker pretty much prevents fibrosis development with little effect from the dual blocker. Inflammation is quite important in the development of CKD after AKI. So here we used, one of the parameters we looked at was resident inflammatory cells. And here I've shown you the resident macrophages stained with F480. What we saw with IRI was a gradual influx of macrophages into the kidney, which is quantified both in the cortex and medulla at the bottom in the black circles. And we found that there was a reduced infiltration with these cells with the A blocker. I've not shown you the A and B blocker because we saw no effect. We then took these cells out of the kidney, we extracted them from the kidney and looked at them in terms of their inflammatory profile, and we looked at their production of two pro-inflammatory proteins, interleukin-6 and TNF-alpha, and we also looked at one of the anti-inflammatory proteins, interleukin-10, and IRI was associated with an upregulation, as you might anticipate, of the inflammatory proteins and a downregulation of the anti-inflammatory protein, and there was prevention of this up and down regulation with the TA blocker. We also found that IRI made these macrophages more phagocytic. And interestingly, the A blocker didn't prevent this, it actually made them even more phagocytic than they were previously, which was something we didn't quite anticipate. What about the cardiovascular complications? Well, this is the model defined by blood pressure. And this is blood pressure in conscious mice measured using a technique called radiotelemetry. And what you see in the open circles is just healthy control mice. The black circles represent the effects of IRI on blood pressure, and this is just IRI alone without any additional treatment. And what you see is that following IRI, you get an increase in acute surge in blood pressure, which then settles down. But over the 4-week time course of the study, you still see a rise in an elevation of blood pressure of around 5 to 10 millimeters of mercury. And the endothelin A blocker, as you can see, didn't prevent that initial rise, but it did cause blood pressure drop, which was just about the same, if not slightly lower than baseline levels. In addition to blood pressure, we looked at the systemic vasculature, and we looked at how the aorta and resistance vessels, such as you see in the mesenteric vessels, functioned, and whether their endothelium was working in response to compounds such as acetylcholine, which is a vasodilator, and sodium nitroprusside, which is also a vasodilator, but doesn't rely on an intact endothelium. What we found with IRI in the black circles is that there was endothelial dysfunction, both with acetylcholine and sodium nitroprusside, and this was absolutely prevented in terms of acetylcholine responses with the A blocker, and prevented somewhat in terms of the SMP response. That was a systemic vasculature. We looked at the kidney vasculature as well, and what we've developed in Edinburgh, and I say we very loosely, we can take in a kind of anesthetized mouse, we can expose a kidney, and we can put 2 probes into the cortex and medulla simultaneously and assess blood flow in the cortex and medulla. And we can do this in response to challenge agents such as acetylcholine or angiotensin II, for example, and look at vasodilator and vasoconstrictor responses. And what you can see here on the left is the cortex, the right is the medulla. In a healthy mouse, if you infuse acetylcholine, in a healthy mouse with the open circles, you see a nice vasodilatation both in the cortex and in the medulla to some extent. IRI was associated with a reduction in this vasodilatation, which was this reduction was prevented to a degree by the A blocker. But as I said before, these drugs reduce blood pressure, and we all know that reducing blood pressure is good in kidney disease, or at least in chronic kidney disease. So the next question was, well, could all the beneficial effects we were seeing here, all just a product of lowering blood pressure? So we then tried to tease this out, and we used 2 agents, hydralazine and verapamil, both agents that have been around for many years. Both agents lower blood pressure. Verapamil additionally blocks the endothelin system downstream. And here are the blood pressure effects of hydralazine and verapamil in mice receiving who had IRI done for a period this is blood pressure over a period of 5 weeks, with IRI occurring at time 0. And what you can hopefully see with the different circles of green for verapamil and hydralazine grey compared to the endothelin A antagonist is that blood pressure fell to a similar degree. Now, despite blood pressure falling to a similar degree, verapamil, hopefully you can see on the second from right, and hydralazine on the extreme right, hydralazine didn't protect the kidneys, whereas verapamil did. So it appeared that blood pressure reduction, but endothelin blockade at some point along the pathway was important. And actually, in the interest of time, I'm not going to go into this, but we looked at how verapamil might be protecting the kidneys, and it appeared to protect a number of injurious pathways. So in summary, hopefully I've shown you that in this work, the endothelin pathway, probably alongside many other pathways, is important in mediating the chronic kidney and cardiovascular consequences of AKI. And blocking the A receptor, certainly, whether with slightly more expensive or very cheap drugs, was quite beneficial. And the question we now have is, well, what do we do? How do we do a clinical trial? Which drug do we use? Which patients do we do this in if it's such a heterogeneous population? And can we use other endpoints that, for example, Nick Selby might be developing using MRI as short or medium-term endpoints in these studies? So thank you very much. I'm very happy to take questions.
That was a great question, and great talk. Because if first to actually see again drugs which can be used for this difficult syndrome. I'm going to go back to just a question which we have in the Q&A, which is probably best it's directly asked for both questions from Jeremy Hughes, who's an eminent nephrologist. Follow-up for AKI patients, are there any utility in routine clinical parameters or biomarkers which could be used to stratify the most appropriate patients to follow up more intensely? I'll maybe put that to you, Nick, first of all.
I'll try and be quick. I think the current guidance suggests that everybody who's had an episode of AKI has a kidney function and ACR checked at least once within 3 months. And the NICE CKD guidelines go even further and say that patients should be followed up for 2 to 3 years, I think, after an episode of AKI. And clearly there's a tension there with the large number of patients and workload that comes along with that. So I think the short answer is there are some clinical risk scores that have been developed that predict either progression to CKD stage 4 or hospital readmission and mortality that have been reasonably well validated. They got reasonable performance, but they haven't really made it into clinical practice. We've done some work with a panel of biomarkers at day 90 and identified soluble TNF receptors and cystatin C, which may actually be just better markers of filtration, so better than creatinine-based estimates of EGFR at that point, that actually are better than EGFR and ACR predicting CKD progression after 3 years. So I think there are some different options that might come in the future, but not quite yet. So I think we're left with a huge unmet need, definite opportunity for sort of addressing low-hanging fruit by just improving some of our follow-up, but work still need to be done to define which patients and also the best care pathways.
Yeah, thank you for that. In the interest of time, there is another question or two coming through in the chat, but I think the question could wait until after your talk. And I wondered, Nick, if you're okay to get your slides up and running, because I'm aware I gave you all fairly tight timelines and then we could just talk over it. So do you want to get your slides up and tell us where the future of this condition is? Bearing in mind that we've said it's extremely common, affects loads of patients, loads of awful things, and there are translational therapies. What does the future of AKI research look like?
Yeah, so in just a few minutes, you've given me an almost impossible task, Paddy, so thank you for that. But I'll do my best to just try and draw together some of the aspects that we've discussed so far and maybe highlight some of the key areas that we need to address to sort of make progress in that. And I think really the future of AKI research has to be grounded in clinical need. So we need to answer research questions that will produce impactful results. And this is a well-known KDIGO diagram that summarizes the continuum of AKI, and it's probably a good way to visualize the different aspects of AKI management and may lead us into that second question that came in the Q&A. So this encompasses patients before they've developed AKI at increased risk, so trying to prevent the onset of AKI. The second is there's a clear need for improved detection and diagnosis for two reasons. We've already suggested that serum creatinine is not a perfect marker of AKI, and it rises late, so you can see declining kidney function and the onset of kidney damage before it can be detected with creatinine. And creatinine is just a surrogate of glomerular filtration. It doesn't provide any meaningful information about different types or biological processes that might be underlying kidney damage. And then once AKI is established. We clearly need better treatments than we have to try and stop progression to more severe stages of AKI. And then the fourth category is, can we improve recovery and improve recovery of maybe kidney function as the number one priority there, but also, as been said, address cardiovascular health in the long term. We've also mentioned several times already that the current status of AKI management is generally supportive, as summarized on this slide, and there are no specific therapies to prevent, treat, or improve recovery at the moment. So across these different categories, the areas in red are maybe some areas that we're seeing the biggest focus in AKI research at the moment. But probably the end game is that we need to have more randomized control trials of interventions, and at the same time try and increase the chances of these trials being successful, noting the both increased pipelines of new drugs coming through, opportunities of repurposing drugs, but also learning from the lessons of previous AKI trials that traditionally it's been a bit of a graveyard, and there's certainly been a number of examples of failed clinical trials in this area. And I think trial design in AKI is a whole talk or a whole hour's discussion in itself, but there are some important considerations just to pick out and may help explain why some previous trials in the past have failed. We've said many times already this evening that AKI is a heterogeneous syndrome. So how do we ensure that we are selecting the right patients to be recruited into a trial for a specific intervention? I think we need to move on from maybe an excessive focus on prevention in previous trials and think more about interventions to treat AKI after its onset. And then that links into choice of outcomes for trials. So endpoints in prevention trials that are based on serum creatinine or the onset of AKI as defined by serum creatinine may be fundamentally flawed, and increasingly we're seeing the use of endpoints such as MAKE or major adverse kidney endpoints, and maybe we can discuss the pros and cons of that if we have time. But it's good to see that acknowledgement of longer term and outcomes and recovery of kidney function starting to enter that category. In addition, I think you could maybe say previous clinical trials might have failed because the traditional approach of identifying interventions targeting a single biological pathway for AKI hasn't really worked. And we've seen examples of failures to translate effective interventions in animal models into humans. And so some recommendations would maybe suggest a different approach, a reverse translational approach, where we start by understanding the human syndrome of AKI better, trying to identify different categories or subphenotypes of patients. And from the human pathophysiology, then develop animal models that link to that a little bit more closely than we have done previously. We've already said that AKI in clinical settings is a heterogeneous syndrome, and I've already shown you this slide already. And that's very much in contrast to animal models, where the kidney injury in experimental settings is often very, very discrete. And if we look at the biggest group of patients, so those that we sort of lump together under the terminology of pre-renal AKI, our clinical approach to this usually crosses these nosocomial boundaries and makes us think about sepsis, volume depletion, and heart failure as essentially the same process, all to do with reduced perfusion. And that's just simply not true. This is a really nice study that combined clinical studies with experimental models of AKI, and showed very clearly that there were very different biological responses to AKI due to simple volume depletion versus AKI with acute tubular cell necrosis. And the activated gene sets in these two situations were completely different, completely functionally unrelated transduction pathways, and they were expressed in different parts of the kidney. So moving forwards, maybe we need to improve on the current situation where we characterize the syndrome of AKI based on changes in serum creatinine or urine output, and actually start getting better at identifying subphenotypes of AKI based on clinical parameters, sure, but also incorporating new information, so biomarker information, genotype, that type of data. And ultimately, where we'd like to get to is having endotypes of AKI. So these are different groups defined by a shared pathophysiology. And this is really then where targeted therapies are much more likely to work. So how do we get there? And maybe biomarkers of AKI is one aspect to consider. And certainly there are a number of biomarkers that indicate tubular damage, vascular or glomerular damage. And it's a huge area of AKI research, but we haven't really seen translation of these biomarkers into clinical care. But despite that, there are themes, and this is a well used figure really that tries to sort of show the link between functional AKI defined on changes in serum creatinine and those defined based on biomarker positivity. And whether or not you have a change in serum creatinine, if you have a biomarker that's positive showing kidney damage, your outcomes are worse. And if you have the two together, so reduction in kidney function and biomarker positivity, then that's the worst outcome of all. And that's a very consistent signal across a number of different biomarkers, even getting towards the phase where some are recommending a change in the way that we classify AKI to incorporate biomarker positivity or negativity into the KDIGO recommendations. Maybe more tractable, however, is thinking about how biomarkers link to interventions. And there are now examples of biomarker-enabled randomized control trials. So this is just one example, using a biomarker to select patients after cardiac surgery. And those patients who had a positive biomarker suggesting kidney damage immediately after cardiac surgery, they were the patients who were recruited and randomized to an intervention to try to improve supportive AKI care. But I think there's more work to be done on this, and more work to really better identify subphenotypes of AKI and link this more closely to trial design. And there is current efforts under the way in a number of areas, but in the UK, Nurture AKI is being developed as part of an industry academic collaboration through the AKI clinical study groups, and hopefully that will really sort of advance some of that. There's 3 cohorts within the study looking at AKI to CKD transition, cardiac surgery, and importantly pediatrics, which is quite different from many other studies, and bringing in imaging and biopsy into this work. I haven't really got to time to discuss this in detail, but I think an area of huge potential is thinking about how imaging techniques might allow us to generate quantitative measures of the different aspects of kidney structure or function that inform about pathophysiology. And as I mentioned already, that's being incorporated into Nurture AKI and may provide a different approach to assessing outcomes or response to an intervention. And so very quickly then, just to sort of circle back to our long-term outcomes and think about interventions to improve long-term outcomes of AKI. I think the first thing to say, and going to sort of Jeremy's question really, is there's a huge amount of low-hanging fruit because many patients after an episode of AKI receive no follow-up at all. So we're currently working through a study that hopefully, from a patient-centric approach, will allow us to sort of define optimal care pathways for post-discharge AKI, linking together both secondary and primary care follow-up strategies. And then these new pathways may be an intervention that can be tested in trials. but also repurposing new therapies. And as we said before, SGLT2 inhibitors from the outcome trials suggested potential protective effects against AKI episodes, which were different from any of the other anti-diabetic drugs. And early data, but even some hints that SGLT2 inhibitors may improve recovery after an episode of AKI. So that was a very sort of quick run through and not comprehensive at all due to time, but hopefully just an overview of some of the areas of clinical research in AKI that I think is exciting and certainly offers opportunities going forward. And I'll finish there and hopefully leave a little bit of time for discussion.
That's great, Nick. Thank you very much for that overview, because I think this is the so what factor, and actually there's loads, both on the basic clinical stuff as highlighted actually in the question answered by Christian Dellis. There's lots of biomarkers we have, but also there are both therapies and approaches. I'd be interested in sort of Bean's thoughts on the future of research and sort of open it out, because you've obviously got compounds that you've tested in translational work. Do you think you're ready for clinical trials that are going to change outcomes with endothelin antagonism or verapamil?
Yeah, so I think it's a really good question. I think the problem, the two issues is who do you treat? The group being so heterogeneous, do you choose a groups such as those are going to, or more likely to get AKI, such as those under surgeons in cardiothoracic surgery, in whom there'll be other things going on like dialysis, filtration, cardiovascular compromise, in which situation you probably would want to stop any trial drug that you give them. And two, what is the endpoint you use? Because any trial like this, if you choose the wrong people and you follow them up until the endpoint occurs, can be a very costly trial. And so in that setting, what you probably want is a short or medium-term endpoint, which will show you efficacy, which is where I suspect some of Nick's work comes in terms of imaging biomarkers or other biomarkers.
Maybe, what do the regulators think about AKI trials? What is accepted? We've in nephrology, we've fought a long time to say that a drop in 40% of eGFR might be acceptable. What's a reasonable outcome in an AKI trial?
The FDA now accept make probably 90, so major adverse kidney events. So that's a combined endpoint of death, dialysis, and non-recovery of kidney function, which is defined as a 25% or more drop in eGFR. So that is the sort of commonly cited endpoint now, and really there's pros and cons of that as an endpoint, I think. But I think it is a step on from prevention trials that are based on serum creatinine definitions of AKI, and those don't always associate with other clinically meaningful outcomes. So that lack of recovery of kidney function, which drives MAKE, is, I think, probably better than what we had before. But as being said, even MAKE 90, they're big clinical trials to show an impact on that.
Okay, on where we were moving into our last minute, so I'd like to round up by highlighting that that this is such an important topic across multiple specialties, with lots to learn, but lots of research now starting to genuinely move forward, where I think it hadn't seen a lot for a while, and it's clearly that the numbers, it's increasing due to diagnosis, but also the multimorbid population we have. This is a big problem. So thank you very much for both our panelists. So this all has been recorded for Zoom, so it should be a great educational resource going forward. And as Association of Physicians, we are going to continue with these educational webinars. So I look forward to being a delegate rather than chairing the next one. But thank you to everyone. And I don't know what it's like with you, but in Glasgow it's a very sunny evening. So after this, I will be going to sit in the garden for a little bit and relax. But thank you very much.
Thanks, everybody. Bye.